Gastroesophageal reflux disease. Etiology, Pathophysiology, and Pathology. Reflux of gastric acid into the lower esophagus can cause mucosal injury, reflux esophagitis. Chronic reflux esophagitis may induce the appearance of ectopic gastric and intestinal mucosa in the lower esophagus, gastric or intestinal metaplasia, a change termed Barrett's esophagus that is considered premalignant because it is associated with an increased risk of esophageal adenocarcinoma. Chronic reflux esophagitis may also lead to fibrotic healing and the formation of a peptic stricture. Incompetence of the lower esophageal sphincter is the main factor in reflux of acid. Gastric acid secretion is usually normal. Hiatal hernias, occurring in 10–15% of the general population, are more prevalent with increasing severity of reflux disease and may contribute to abnormal reflux by both reducing basal lower esophageal pressure and impairing effective esophageal clearance of acid, Fig 25. Reflux may result in a spectrum of damage to the esophagus, ranging from microscopic changes only through to circumferential esophagitis with ulceration and stricture formation. This can be graded using the Savary-Miller classification. Grade 1, one or more non-confluent erosions. Grade 2, confluent but not circumferential erosions. Grade 3, circumferential erosive esophagitis. Grade 4, Grade 3 plus ulceration, stricture formation, or Barrett's esophagus. Epidemiology. Gastroesophageal reflux symptoms, retrosternal burning, acid regurgitation, are common and occur on a daily basis in up to 10% of the population. Only about 1/3 of patients will have endoscopic evidence of esophagitis. Peptic strictures occur in 7–23% of patients with untreated reflux esophagitis. Clinical presentation. Common. Burning retrosternal pain aggravated by lying down or bending forwards, and by spicy foods, citrus fruits, and alcohol. Regurgitation of acid, water brash, chest pain, odynophagia, painful swallowing, and dysphagia. NB. Esophagitis and Barrett's esophagus can be entirely asymptomatic. Conversely, reflux symptoms can be severe without endoscopic or histological evidence of esophagitis. Uncommon. Hematmesis or iron deficiency anemia. Physical signs. Usually no physical signs. Occasionally, severe acid reflux into the pharynx can lead to hoarseness and pharyngitis. Weight loss if there has been a delayed presentation of an esophageal stricture. Investigation and staging. Upper gastrointestinal endoscopy. Indicated if troublesome or refractory reflux symptoms. NB. Gastroscopy is mandatory in those who have alarm symptoms, hematmesis, dysphagia, weight loss, anemia, and desirable in middle-aged or elderly patients with new onset of symptoms. Patients in their 20s or early 30s who require infrequent, intermittent courses of acid-suppressing therapy probably do not warrant endoscopy, but those with persistent symptoms requiring long-term therapy should be examined to define the extent and severity of esophagitis, or presence of Barrett's esophagus, and thereby guide therapy. Esophageal manometry and 24-hour ambulatory pH monitoring. This is useful in patients with atypical symptoms, in those who do not respond to acid suppression therapy, and as part of the workup for patients considered for anti-reflux surgery, along with esophageal manometry. Differential diagnosis. Common differential diagnoses include the following: cardiac pain, esophageal carcinoma. Benign-looking peptic strictures must be brushed and biopsied to exclude malignancy. Infections with herpes simplex or candida. Drugs, e.g. alendronate, NSAIDs, ferrous sulfate, potassium salts, that may cause esophagitis. Radiotherapy-induced esophagitis, e.g. treatment of bronchial carcinoma. Treatment. Emergency. Patients with dysphagia need rapid assessment with either a barium or gastrograph and swallow followed by endoscopy. Barium swallow is usually performed first to define the position and extent of any stricture. Patients with a stricture demonstrated on barium swallow should proceed to endoscopy for biopsy and brushings to exclude malignancy. All patients with benign peptic esophageal strictures should be commenced on a proton pump inhibitor, PPI, to prevent further acid reflux and damage. Concurrent esophagitis per SE may contribute to the dysphagia. If symptoms are significant, esophageal dilatation should be performed. Initial improvement occurs in greater than 80%, although 1/3 require repeat dilatation within 12 months despite acid suppression therapy. Short-term. Treatment of uncomplicated gastroesophageal reflux should be directed at alleviating the symptoms. A graded approach is usual, starting with antacids and lifestyle measures, stopping smoking, avoiding precipitants, then histamine H2 receptor antagonists with or without prokinetic agents, e.g. metoclopramide, and finally PPIs or anti-reflux surgery. When esophagitis is demonstrated endoscopically or microscopically, aggressive initial treatment with a PPI, followed by an H2 receptor antagonist, and eventually symptomatic treatment with antacids should be initiated. Healing of esophagitis, grade 2 or more severe, is desirable to prevent complications such as stricture formation or Barrett's metaplasia. Long-term. Many patients with symptomatic gastroesophageal reflux relapse following cessation of medical therapy. PPIs are the most effective agents in the initial healing of reflux esophagitis, 80–90% within 8 weeks with standard doses, and in subsequent maintenance therapy. Aggressive acid suppression therapy with PPIs has been shown to decrease the need for repeat dilatation of esophageal peptic strictures. Complications. Common. Most patients with gastroesophageal reflux disease can be well controlled with acid suppression therapy. Relapse of symptoms is common on withdrawal of treatment. It is estimated that up to 1/4 of patients with untreated reflux esophagitis will develop strictures. Long-term acid reflux is important in the development of Barrett's esophagus. Prognosis. The advent of the powerful PPI agents means the vast majority of patients can be rendered asymptomatic. Anti-reflux surgery is an alternative where medical therapy fails, or if the patient is young and unwilling to take medications indefinitely. Although reflux disease has little effect on life expectancy, it may predispose to the development of esophageal adenocarcinoma. Long-term severe reflux predisposes to Barrett's esophagus with its malignant potential. Prevention. Aggressive control of acid secretion is likely to be important in preventing peptic stricture formation in those with significant reflux esophagitis. Once a stricture has formed, long-term therapy with a PPI is indicated. Disease association scleroderma may result in severe esophagitis and stricture formation.